Picture this. It's 1933. You need a surgery. The anesthesiologist approaches with a bottle of ether and a cloth mask. You know what's coming next. Minutes of choking, gagging, that suffocating feeling as you fight with the mask. Your heart starts racing, the room feels spinning. It's absolutely terrifying. Now imagine, snap, in one injection, 5 seconds and you are peacefully asleep. That single moment, that revolutionary shift, happened in 1934 when thiopental entered the scene. And here's what mind-blowing. That one drug from nearly a century ago still teaches us everything we need to know about modern IV anesthetic drugs. Hey everyone, welcome back. I'm so excited you're here because today we are not just memorizing facts about thiopental. We are going on a journey. We'll uncover why this drug works, how it changed medicine, and here's the best part. Once you truly understand thiopental, you'll understand propofol, etomidate, and every other IV anesthetic. And stick around to the end because I'm going to show you exactly how to write a killer exam answer on this topic that will make your examiner smile. So grab your coffee, get comfortable, and let's dive into the fascinating story of thiopental. Let me take you back to 1934. Anesthesia was, let's say it was just brutal. Diethyl ether was the standard. Imagine being a patient now. The doctor starts with the mask. You smell that pungent sweet smell and then begins the excitement stage. 10, sometimes 15 minutes of fighting, coughing, maybe sometimes vomiting. Absolute chaos in the operating room. Then comes the thiopental. Inject 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, and the patient's unconscious. Clean, smooth, and this was revolutionary. Now here's something you might not know. Thiopental isn't even exported to the US anymore. The manufacturers protested its use in capital punishment. But what's mattering to us is it's still used internationally and more importantly remains the gold standard in every pharmacological textbook, every research paper, and every comparison study. Whenever scientists develop a new IV anesthetic, they compare it with thiopental. So it is the standard. Okay, next. We'll discuss about the chemical structure and structure-activity relationships of thiopental. Now I know what you are thinking. Chemistry? Really? Do I need this? Yes, we need this. And I promise to make it interesting. Because this one simple chemical change explains everything about thiopental. Look at the position 2 on the barbiturate structure. In most of the barbiturates, it is oxygen. But look at it in the thiopental. It is sulfur. And that one atom changes everything. Because sulfur makes this highly lipophilic. And your brain literally is 60% fat. Hence, thiopental doesn't just cross the blood-brain barrier but races across it like it has got a VIP pass. That's the secret to this 5-second knockout. We have counted as 1 Mississippi, 2 Mississippi, right? Same thing. It's not magic. It's chemistry working at the speed of blood flow. Now here's where the drug design gets absolutely fascinating. Now watch out what happens when we make such minor, tiny structural changes. Start with oxygen at point 2. Position 2 oxygen, it's pentobarbital. This is a decent drug. Nothing special with less lipid solubility and lower potency. Then comes sulfur at position 2. That is the thiopental. Way more potent, way more faster. Rapid onset of action. Then you add a phenyl group at position 5. That will become phenobarbital. Now from an anesthetic, suddenly you have got a anticonvulsant. But weirdly, it's not more sedating. So these drugs, the thiopental, it's a sedative drug. But this phenobarbital is not much of a sedative. Then, now you add methyl group to the nitrogen. There is a methyl nitrogen, and to that you are adding a methyl group. You are adding two groups here. Now it becomes methohexital. This is a drug that's more hypnotic and also more likely to cause seizures. That is, this is the only drug in the barbiturates which can lower the seizure threshold instead of raising it. Generally, this is an anticonvulsant. That means it's raising the seizure threshold. But here methohexital lowers the seizure threshold. So it's like a mixing board, right? Each structural change is turning a different knob and you get different structures. So now let's see how it works. The target is the GABA A receptors. Think of these as your brain's calm down switches. GABA A receptors are, GABA is a inhibitory neurotransmitter. So more of GABA is activated, the brain gets into a calm down switch. Now GABA, being a natural neurotransmitter, is the key which opens the door of the GABA receptor. But thiopental is not like, it does not replace the GABA position of GABA. It increases the GABA affinity to the GABA channel by binding to a site other than the site of GABA. That is, it's an allosteric inhibitor of a GABA A receptor. And then after this allosteric inhibition, chloride ions, it increases the keeps the chloride channel open for longer duration. That is called the hyperpolarization. Increases chloride inflow, and that leads to its less neuronal firing and causes consciousness, loss of consciousness. And a bonus fact for you, at really higher doses, thiopental can actually skip GABA entirely and just open those doors itself. So what we have spoken, thiopental is an allosteric inhibitor, modulator of the channel. That is, it allows for more binding of GABA and potentiates the activity of GABA, prolongation of opening of receptor. But at high doses, instead of GABA, it itself can do the action. Now, this is the most important concept in the entire session, the next one that we are going to talk. Grab a pen, open your notes, because this explains not just thiopental but everything. Now, let's imagine a journey. We are now it's like a story now. You inject thiopental into a vein. Within one circulation time at about 30 seconds, it's flooded into your brain. Why is it so fast? There are two reasons. One, the brain gets 15% of your cardiac output. So, it's a VIP organ with a premium blood delivery. And two, thiopental is super lipid soluble. Remember, it crosses the blood-brain barrier like it's not even there. So, patient becomes unconscious within seconds and the surgeons are happy in a moment. Now, the drug doesn't just sit in the brain like a lazy tenant. It starts looking for other places to hang out. First stop goes to the skeletal muscle. Muscle has a decent blood flow, not as good as brain but enough. This drug starts moving there. Next stop, the fat tissues. Fat has even less blood flow, but thiopental loves fat. Remember, it's lipophilic. So it slowly migrates there too. As the drug leaves the brain concentration drops. And when the brain concentration drops below a certain threshold, the patient wakes up. Only now, long after the patient is awake, chatting, asking for ice chips, does this liver slowly metabolize the drug over hours and hours. So, initial phases, the phase of unconsciousness, rapid uptake into the brain. Once the blood supply slowly, as it distributes, it goes to the skeletal muscles. That is the phase where the awakening begins. Redistribution happens and it goes into the skeletal muscles. Within time, again it starts depositing into the fat tissues. After all this happens, then the metabolism starts in the liver. A pop quiz time. Why does the patient wake up after a single dose of thiopental? Three options. The liver metabolizes it super fast. The kidneys excrete it quickly. It redistributes away from the brain. The answer is C, redistribution, not metabolism. And the mantra I want you to repeat here is brain to muscle to fat. Brain to muscle to fat. This pathway will save you on exams, clinical practice, and understanding every IV anesthetic made. Here's the clinical pearl. Look at your PDF where I have shown the plasma concentration curves. See how after one dose the concentration drops rapidly, not because it's being eliminated, but it's being redistributed, hiding in the muscles as well as in the fat tissues. See, the concentration is here, but the patient is awake. And this is critical. If you give it as an infusion hour after hour, what happens? Those muscle and fat compartments get saturated, they are full, they can't hold any more of the drug. So when you turn off the infusion, the drug has nowhere to go now. It slowly leaks back into the bloodstream. The plasma level doesn't drop. The patient stays asleep and asleep and asleep. This is called a long context sensitive half time. The context is how long you have been giving it. Bottom line, do not use Thiopental for continuous infusions. It accumulates like crazy. This is exactly why Propofol took over. It doesn't pile up the same way. But understanding this principle from Thiopental makes you understand why we choose different drugs for different situations. Now, let's talk about how age changes everything. Because a 3-year-old, 30-year-old and an 80-year-old are not same when they come to the hospital. First, the kids. The metabolic powerhouses. Here's something that surprises people. Children actually clear Thiopental faster than adults. Their little livers are metabolic machines. So, after big or repeated doses, kids wake up quicker than you would expect. Don't underdose pediatric patients thinking they are more sensitive. They are not. They metabolize it faster. Elderly. They are slow and steady. Now flip to the other end of the spectrum. In elderly patients, the drug moves more slowly from the central circulation to those peripheral tissues, muscle and fat. Why? Decreased cardiac output, changes in the body composition as well as reduced tissue perfusion. So the drug hangs in the brain longer. They need lesser drug. So start low and go slow in elderly. Pregnancy. This one's super specific and it's an exam favorite question. In first trimester, specifically in 7 to 13 weeks gestation, they need about 18% less Thiopental. Why? Because hormonal changes, increased sensitivity, altered pharmacodynamics. After that window, requirements again change. Right? Now this is where theory meets the clinical practice. Let's talk about a story. Now, you have seen a patient who is in hemorrhagic shock and you have given a standard induction dose of Thiopental to the patient. What happens to the blood pressure? It crashes to 60 systolic. Why? Because we have not adjusted the dose to the most important factor, the cardiac output. So as spoken, now let's discuss where the dose has to be reduced. 1. Elderly patients, they need less. We already talked about this. Slower redistribution, the drug hangs over in the brain for longer duration. Early pregnancy, the magic 7 to 13 weeks window where you have to reduce the dose by 18%. And hypovolemia, less blood volume means the dose required, same dose but still higher concentration will be achieved. Hence, you have to reduce the dose also. Low cardiac output. Now think of this very carefully. If the heart is pumping weakly, the blood also flows less through brain per minute. But you are still injecting the same amount of drug into the smaller volume of blood. That means the drug concentration in the blood reaching the brain is much higher than you have intended to. It's like if 10 people normally share a pizza, but only 5 show up. Each person gets way more pizza than expected, right? It's the same. The patient's in shock, heart failure, severe hypovolemia, they can crash even with normal doses. You absolutely must reduce the dose. Definitely. Factors that increase the dose when needed. Thermal injury patients, specifically children more than 1 year post-burn. These patients undergo profound physiological changes in the body. There will be increased drug clearance, tolerance mechanisms kick in. So it's a real phenomenon and you must do it. And now the myth buster. Ready for something that will surprise you? Chronic alcoholism does not increase dose requirements. At least not if the patient has been abstinent for 9 to 30 days prior. Clinically, it feels like alcoholics need more drug, but when you looked at the controlled studies which have been done after the abstinence, there was no such difference. And this is a great example of why we need evidence-based medicine. Our gut feelings aren't always correct. Next, now let's get practical. When would you reach for thiopental? Why do you need thiopental? And in this current era, why do you need it? Let's talk about it. First, induction of anesthesia. Honestly, in most developed countries, you wouldn't. Propofol has taken over. Why? Propofol causes less nausea and vomiting, and patients hit recovery very fast. But, and this is very important, for a single dose, awakening times are actually similar between thiopental and propofol. And in resource limited settings and in developing countries, thiopental is still doing the job it was designed for. It's cheaper, it works, and it is reliable. Pre-medication, it used to be a thing. Thiopental before surgery calm patients down, but there is a risk of hangover and patients are groggy for hours. Hence, benzodiazepines like midazolam have replaced it. You get anxiolysis without the prolonged sedation in using benzodiazepines. Seizures. Thiopental absolutely works for grand mal seizures. Whenever you give it, the seizure stops. But still, benzodiazepines are better. More specific anti-seizure mechanisms and with less cardiovascular depression has been seen with benzodiazepines. Then, in an uncooperative patient. Now let's imagine. It's 2 a.m. A terrified 3-year-old in the ER needs a CT scan to rule out an intracranial injury. Won't let anyone near him. Parents are exhausted, but you need that scan. What will you do? You can give rectal methohexital 20 to 30 mg per kg, and when the plasma level hits 2 micrograms per ml, the child drifts off to sleep. It's not an elegant choice, not a first choice, but when you need it, it's gold. Then we are actually coming to the point where thiopental is needed. In raised ICP, increased intracranial pressure. This is where the thiopental really shines. Let me walk you through this mechanism like a cascade. What will thiopental do? Thiopental causes cerebral vasoconstriction. Blood vessels in the brain squeeze down. Smaller vessels, less blood volume in the skull. Less volume, less pressure. That is reduced intracranial pressure. You can titrate this all the way to burst suppression on the EEG. Those alternating flat lines and bursts of activity. At an isoelectric EEG, you have maximally depressed cerebral metabolism by up to 55%. And this is perfect in a patient of head trauma. But here's the truth. The pros of it are, it's great for inducing patients with elevated ICPs and can cause rescue in refractory ICP cases that won't respond to any other measures. But the cons are, it causes a significant hypotension and can tank the blood pressure dangerously. Despite making the ICP number looking beautiful, we have no good evidence that it improves outcomes in head trauma patients. We can make the monitor happy, but we haven't proven we save more brains. So that's a thing we need to take care of. And then cerebral ischemia. Global ischemia, its efficacy is unproven. Multiple trials have been done but no clear benefit. Focal ischemias like in stroke or partial brain affected, animal studies have shown it promising, but the idea is thiopental decreases oxygen demand more than it decreases blood flow. So underperfused areas might be protected, but in humans still not routinely recommended. What is best? Moderate hypothermia is best. Cooling to 33 to 34 degrees Celsius. It is the simplest intervention which works best. Now let's talk about methohexital, thiopental strange relative. What is common in methohexital and thiopental? What we have read about both of them? How are they both related? Methohexital has nitrogen attached to a methyl group in place of sulfur, right? Do you remember? Nice. And we have already spoken about it. Methohexital does not raise the seizure threshold like every other barbiturate. It lowers the seizure threshold. So, this is perfect for two specific situations. One, in epilepsy surgeries. So, here in epilepsy surgeries, you needed to find the seizure focus in the temporal lobe. You give methohexital and that focuses the light up. Neurosurgeon maps it precisely. And in ECTs, you need good seizure for the ECT to work. Methohexital gives you a longer seizure duration than other agents, and this is the preferred drug now. But what is the downside of it? High rate of excitatory phenomenon causes myoclonus, that is muscle twitchings, hiccups and involuntary movements. Dose dependent and honestly pretty annoying to watch a patient in this. You can also do something, a pro tip here. Give an opioid first, a fentanyl or remifentanil, reduces these movements, and then you can give methohexital. It's not used for routine cases, but when you need it, nothing else works like methohexital. Now let's talk about the cardiovascular effects. In a normal healthy patient, giving about the induction dose is 4 to 5 mg per kg IV, and giving it, the blood pressure drops by 10 to 20 mmHg, heart rate goes up by 15 to 20 beats per minute. Both are transient, mild and compensatory. In healthy patients, it's no big deal, mild and brief, but where does this hypotension come from? This is what we have to understand. Primary mechanism is by peripheral vasodilation. The blood vessels relax and dilate. Secondary mechanism, which we should also know, is it causes depression of the medullary vasomotor center, the brain's blood pressure control center, which gets sleepy. And yes, it's not a direct myocardial depressant at clinical doses. That means the heart muscle itself is fine. And this is the reason why hypovolemic patients crash so hard. They are already vasoconstricted to their maximum. That is, they are barely maintaining their blood pressure. You give thiopental, the vessels start dilating. Suddenly, whatever they were compensating through vasoconstriction, that mechanism you have blocked. That means they'll crash. So you have to always reduce dose in cardiovascular compromised patients. Then talking about breathing. It's also important, right? Thiopental depresses both the medullary as well as the pontine ventilatory centers. That means the brainstem areas which control normal breathing. It also decreases the carbon dioxide sensitivity. The body is normal, I need to breathe signal. This leads to dose dependent respiratory depression. So you give more drug, more depression. And what is the danger here? It can lead to apnea, and especially when you combine with other respiratory depressants like opioids. For example, you give fentanyl for the IV stent. Then you give thiopental for induction. So the patient definitely stops breathing here. So after induction, the breathing pattern slows respiratory rate, shallow tidal volume, and there is no ventilation from the patient end. And the laryngeal and cough reflexes stay intact until you give larger doses. So the patient might still cough or gag during intubation if you're not deep enough giving your anesthesia. What are the clinical takeaways here? You have to always be prepared for apnea, keep your bag and mask ready, airway equipment ready, and you have to expect that you have to ventilate every patient after induction. There is no exceptions ever. And if you want your airway safety checklist, DM me and I'll share it with you. Now the neurophysiological monitoring. If you're doing an intraoperative neurophysiological monitoring, can you use thiopental? We will discuss about this in detail in our coming videos. Then talking about complications. First main important complication, after 2 to 7 days of sustained barbiturate use, the liver ramps up its drug metabolizing machinery. So what happens? It causes enzyme induction. That means what are the other drugs which are affected? Oral anticoagulants, you have to either increase the dose, if not the patient's clot. Phenytoin, patients will cease. Tricyclic antidepressants, corticosteroids, bile salts and vitamin K. These all are rapidly metabolized, hence it's a warning. Barbiturates create a real clinical problem if used for chronic use. And they also accelerate heme production. In patients with acute intermittent porphyria, which is a genetic condition, this can trigger a life-threatening crisis. So barbiturates are absolutely contraindicated in porphyrias. Then the main emergency situation is intra-arterial injection. Nightmare scenario. You think you are in a vein, but when you inject thiopental, you find out it's an artery. What happens? Immediately vasoconstriction, excruciating pain shooting down the arm. Distal pulses vanish. Hand initially goes white and then goes blue. Without treatment, it can even go to gangrene, nerve damage, and possibly it can cause even amputation. This is a true emergency, like every second counts here. Immediately you have to do 3 things: dilute, dilate and circulate. Leave the needle in, don't pull it out, and you have to inject saline through the needle so as to dilute the drug. Then inject vasodilators through the same needle like lignocaine or papaverine. They'll reverse the arterial spasm. Maintain the blood flow. You can use stellate ganglion blocks, systemic vasodilators, or do any supportive care. Prevention, always pull back, check for blood. Venous blood is dark, arterial blood is bright red and pulsatile. When in doubt, use an ultrasound. It's must. Regarding the mechanism, why does it happen? Give your answers in the comments. We'll pin the comment. Then the allergic reactions. Incidence is rare but not impossible. There are 2 types of allergic reactions. True anaphylaxis, which is antigen antibody mediated, or the anaphylactoid, which directly cause histamine release. And this can happen without prior exposure. First time thiopental can still react, and many patients who react had tolerated it fine in previous surgeries also. So major risk factor, history of chronic allergies or atopies. What will you do in the management? Stop thiopental immediately. A first line drug is epinephrine. IV fluids in massive volumes, antihistaminics, first generation or second generation works. Supportive care. First thing what you have to check is stop thiopental immediately and check for ABC, airway, breathing, circulation. Then start giving the drugs. Red flags here are sudden cardiovascular collapse, bronchospasm, urticaria right after induction. Anaphylaxis protocol, DMA I'll send you. Then now let's do a comparison game. Thiopental being our baseline where potency is equal to 1, comparing with thiamylal and methohexital. Thiamylol is pretty much identical drug with a potency of 1.1. Same drug, just a different side chain. Methohexital, that is what we have compared this way, and its potency is 2.5. That is very higher, 2.5 times more powerful per milligram. So to get the same effect, you need less than half the dose of methohexital. But why? Now let's talk about some chemistry. Normal blood pH is 7.4. At the blood pH of 7.4, methohexital is 76% non-ionized and thiopental is only 61% non-ionized. Why does this matter? Only the non-ionized form can cross cell membranes. It's uncharged, so slips through the lipid bilayer very fastly. More non-ionized fraction, more drug gets into the brain and the effect will be also more potent. It's like having a VIP pass to the concert versus waiting in the general admission line. Okay, methohexital has the VIP pass. Right? Now, before we wrap up, let's learn about some most known facts, and I call them the desert island facts. If you could only remember 10 things about thiopental, these are the 10 things you must remember. The first, single dose duration is because of redistribution and not metabolism. It is from brain to muscle to fat. This is the foundation. The most important dose factor is cardiac output. Low cardiac output, higher brain concentration, so you have to reduce the dose significantly and must. You should never miss about it. Structure determines its function. It has sulfur at position 2, making it highly lipophilic, so rapid onset of action rapidly enters the brain. Within 5 to 10 seconds, the patient is induced. Never use it for continuous infusions because it has a long context sensitive half-life. There is drug accumulation and there will be prolonged sedation. That is what we call the residual effects. And ICP mechanisms, it causes cerebral vasoconstriction, reduces cerebral blood volume and thereby reduces the intracranial pressure. 99% of the drug is metabolized in the liver, but this is irrelevant for our single dose. Single dose is due to redistribution, which makes the patient wake up long before even it is metabolized. Hypotension because of peripheral vasodilation, and it's not because of myocardial depression. Myocardial depression happens only at higher doses, not at the regular clinical doses. Respiratory depression always occurs. In every patient, you must be prepared for apnea. Intra-arterial injection is an emergency. The 3 rules are dilute, vasodilate and circulate. These are the words that can save the limb. It is replaced by Propofol but remains the prototype. Why is it replaced by Propofol? Because Propofol is useful for reducing the post-op nausea and vomiting, and also it has no residual effects. The drug is contraindicated in porphyrias. Not only thiopental, any barbiturate is contraindicated. And methohexital is used for ECT because it lowers the seizure threshold and it induces a seizure. Screenshot them, write them on your index cards, tattoo them on your forearm if you have to also. Kidding, but these are must. And that, my friends, is thiopental. From revolutionizing anesthesia in 1934 to teaching us the fundamental principles that apply to every modern IV anesthetic we use today. And we didn't memorize the facts, we understood why. We connected chemistry to the clinical practice and we learned the principles that transfer to propofol, etomidate and midazolam also, which we'll be understanding when we read about them. But now we understand how does the drug structure determine its function, why redistribution matters for thiopental, how to adjust doses for different patients. And before I let you go, I want to hear from you. What was your biggest aha moment in this session that felt like, oh, is this the reason? And drop a comment or DM me on Instagram. I'll give you the concised notes for this, which will be useful for your examinations. And also, or you can also check the link in the description below to download it directly. And hey, yes, if you found this helpful, do me a favor, share it with your classmate who's struggling with the pharmacology. Learning together is more powerful than learning alone. Subscribe and follow for more deep dives into medicine. And next week we'll come up with another drug, and you don't want to miss it. Thank you so much for spending this time with me. I'm genuinely excited for your learning journey and I'm honored to be a small part of it. Now go download those notes, practice those concepts, and absolutely crush your next exam. Until next time, keep learning, keep questioning, and keep being curious. This is Dr. MS Corpus signing off. Stay safe, sharp, and remember, you have got this.